Hello everyone, this is a short video of robotic posterior suture rectopexy in a young gentleman who is around 40 years of age, who is having complete rectal prolapse for last 1 year associated with mucosation, bleeding PR, and during passing stool. It was a grade 3 rectal prolapse. After proper evaluation, he was taken up for robotic suture rectopexy. So Da Vinci X robot was used in patient was in leg split and head down position, and robot was docked in between the legs, and standard port for robotic rectopexy was placed, and using monopolar Caesar and left hand fenestrated bipolar grasper. You can see I'm just incising the peritoneum, staying at least 2 centimeter above the sacral promontory, and identifying, first thing is to identify the holy plane of field, the loose areolar tissue plane through which we have to do the dissection. The most important step is to of robotic rectopexy or rectopexy is to completely mobilize the rectum, and one should bring out the whole of the rectum, starting from the sacral promontory up to the levator ani, and bring out the whole rectum out of the pelvis, and then fix it onto the sacral promontory. So you can see, identifying the loose areolar tissue plane, I am going to this is the same plane where we do the TME dissection. So the same plane is followed. You can see gradual traction with my left hand instrument. Here I am using all robotic 4 arms, where one is for camera, and then 2 arms for right hand left hand instrument, and one robotic arm which is not in the vision, but it is being used for traction of the rectum. So as we keep on dissecting the robot dissecting the rectum, and you can see the traction is gradually lifted off. Traction is gradually given on the rectum to lift up the rectum out of the sacrum, and then the identifying the loose areolar tissue plane, the using tip of the Caesar. It is the dissection is being proceeded by dividing the loose areolar tissue and staying into the holy plane of Hild, and the rectum is being mobilized. The here the along with the posterior mobilization of the rectum, the simultaneous lateral mobilization is also being done gradually. So but important is to lift up the rectum in staying into the correct plane, and if we can stay into the correct plane while doing the rectal dissection, then there will be absolutely no bleeding. You can see the bloodless plane, which is actually being described in by Bill Hill, that this is the plane which is bloodless plane of Hild. So you can see gradually the sacral promontory along with the whole sacral hollow is being visualized, safeguarding the presacral fascia and the nerves covering it. So after posterior mobilization to some extent, the next thing is to medial to, after doing a medial to lateral dissection, the right lateral, after doing the right lateral to left lateral dissection, here is the rectum is reflected onto the opposite side, and the left lateral rectal peritoneal fold is being divided, incision is being given, and a gauge piece was kept, and it was kept underneath the rectum onto the left side, so that while doing the while dividing the peritoneal fold, we can easily identify and get into the same plane that has been created from right to left dissection or medial to lateral dissection from the right side. So you can see now the gauge piece is being clearly visualized. Now we can we are confirmed that we are into the right plane, and then with safeguarding the left ureter, and then the incision is being proceeded further along the peritoneal fold, and if we follow this plane, we will not be entering into the mesorectum, neither there will be no chance of injuring the left ureter also. So all the important vital structure on the left side is the left common iliac, external iliac vessels, internal iliac vessels, left ureter, all are safeguarded in this manner. If we can follow into the correct plane, the correct mesorectal plane onto the left side, so where we can safeguarding the mesorectum, the rectum is being mobilized on while doing this dissection. The traction is giving onto the opposite side toward the right iliac fossa, so the rectum will go onto the right side, and the peritoneal fold is pulled onto the left side, and you have to go in between. Then again further dissection onto the posterior aspect, is being carried forward. So you can see the using robotic console. This is actually what we are seeing is the 2D view, but actually while sitting in the console we can actually see the 3D vision, and there is absolutely fantastic vision, augmented 3D view, or is augmented reality, where you can actually do the fiber by fiber dissection can be done in a bloodless plane, and gradually lift up the rectum from the whole of the sacral hollow without injuring any of the nerves or vessels, and then identify the levator and till the pelvic floor or the levator muscle can be exposed. So you can see gradually the sacral hollow is being fully covered, and the levator muscle is getting exposed now. So up till while the dissection should be carried till we can see the levator muscle, and once we can see the levator muscle, the almost the complete dissection has been done onto the posterior aspect, and now the lateral dissection, remaining part of lateral dissection is being done. But again, the lateral sacral fold should not be divided, because lateral middle sacral vessels and the nerves are coming to the lateral sacral fold. So that should be safeguarded, and now you can just doing a PR examination by the assistant surgeon, we can confirm the adequacy of the posterior dissection, where we can palpate the tip of the instrument. And now the dissection is carried for continued on the anterior aspect. So anterior mobilization should be done to mobilize the rectum, and the plane is in between the bladder and the rectum. So while pulling the peritoneal fold, we have to go in between the plane between the bladder and the rectum, safeguarding the bladder wall, and the seminal vesicle will be coming. So without injuring, there will be a loose areolar tissue plane in between the seminal vesicle and the mesorectum. You can see the S-shaped structure behind the bladder is the seminal vesicle, so that should be safeguarded, that should not be injured. And that plane, the adequate at least 5 to 6 centimeter mobilization of the rectum should be done, and giving proper traction, counter traction, you can actually identify the correct plane. And if you can see stay in the correct plane, in correct loose areolar tissue plane, there will be hardly any bleeding. So till now you can see that I have done the dissection, the complete posterior mobilization till the levator, anterior mobilization till from the separating from the bladder and the seminal vesicle, and to mobilize the anterior aspect of the rectum. Laterally, the dissection is being done till the lateral sacral fold and without dividing it. And when all the 360-degree mobilization is being done of the rectum, then the fixation of the rectum, there is a rectopexy part. So here I am using a 20 silk suture. Those are the polyfilament suture, 20 silk suture, fixing the lateral rectal fold, including the mesorectum, and fixing it with the sacral promontory. So the bite of the bite when the sacral promontory should include the periosteum, just superficial to the periosteum, and the rectum is should be nicely fixed. So two sutures on the right side is being placed, and the rectum is being nicely fixed, so that once you leave the traction, rectum should not slide onto the deep pelvis, and then by that you can check the adequacy of the fixation. Here you can see the how suturing in this difficult anatomical aspect is made easy using the robotic instrument. And the flexibility, the 7 degree of movement of the robotic instrument is actually helping me to do suturing in this difficult anatomical location, whereas in laparoscopic rectopexy, the suturing is a bit technically challenging. So you can see two sutures on the right side, and I have kept one suture on the left side, and the rectopexy is being completely, and you can see the rectum is lying straight and out of the pelvis and fixed onto the sacral promontory. And final step is to closure of the peritoneal fold to prevent any internal herniation in the future. So peritoneal fold should be covered. Here I am using a 30 centimeter V-lock suture, absorbable V-lock suture, to close the peritoneal fold on the right side, and then another V-lock will be taken to close the peritoneal on the left side. So this operation took me almost around 150 minutes. So patient had an uneventful recovery. He was mobilized on the same day. Oral liquids was allowed from POD 0 itself. POD 1 he was completely fully mobilized, and POD 2 he passed stool and soft diet was allowed and discharged on post-operative day 2. He is doing well on follow-up period. Thank you so much for watching this video.